sometimes it's easier to understand pain in MS patient by patient by patient. And just as all the symptoms in MS vary from one individual to another, so does the nature of pain. And remember, pain is not just the fiber endings and what they do, it's how your brain responds to pain. How many people here tell their spouses and their children that they have a high tolerance for pain? All of the women raised their hands, right? Yeah. None of the men raised their hands. I noticed that. Anyway, no, but we all respond to pain in a different way. And that, in fact, tremendously impacts on treatment needed and types of treatment needed. So managing pain in MS has to be highly individualized between you and your providers. And by providers, I really mean the broad spectrum of providers, which can be your doctor and doctors of all kinds, right? And we send people to other kinds of doctors, not just neurologists, depending on what kind of pain people are having. Sometimes it's a gynecologist who's going to help with the pain. Sometimes it is a psychiatrist who's going to help with the pain because there's a psychic basis to that pain. Don't be resistant to all kinds of interventions. Then we have an entire unbelievable MS Center staff at our center that deals with pain complaints on a daily basis. Lisa's back there, Mary's back there. They are fielding, and now Kim, they are fielding calls about pain every day, all the time. And of course, Mary Kay is our premier, meeting with patients and spending hours and hours dissecting various MS symptoms, amongst which pain can be central for many of our patients. Okay, so the kinds of syndromes, though, Amy kind of described for you, and I put them into the same types of categories, and then we're going to talk about cases in each of these categories. So there are pains in MS that are acute and stay a short time and go away. There are pains in MS that come and go, episodic pains. There's pain in MS that's chronic, often neuropathic, and always there to some extent. And then there are these nociceptive pain syndromes that are sort of secondary to the abnormalities that MS may induce or relate to comorbidities, other diseases that our patients have that are piled on top of their MS. So that's introduction. Mary Kay is here to sort of spar with me a little bit on these cases.
This 45-year-old woman develops an ache over her left bra one day while at work. Now she thinks it's just related to working too hard. You know, we all work too hard. She does the computer all day long. And then she thinks, oh, you know what, maybe it's just a tension headache. And I'm just gonna try some Tylenol. That doesn't do much good. Maybe I'll try next time Aleve. Maybe that's a longer acting medicine. Maybe that'll work better. That doesn't work. The next day I'm gonna alternate. Tylenol, ibuprofen, Tylenol, ibuprofen, and it'll go away because everything always goes away, right? Well, it really didn't. It increased. And now it's all around the eye. And she notices when she's looking at a piece of paper, she's got to move it around because she can't see clearly in the middle. She's moving this around because there's a hole in the middle of her vision. By the third day, these symptoms have increased and now have a new intensity to the pain. There's a sharp pain in her left eye, particularly when she looks far to the right or far to the left. She's alarmed now. She calls Mary, and Mary says, you know what, why don't you go to the eye doctor? She says, can I go to the Walmart? I just got my glasses there 2 months ago. Can I go to that Walmart and see that same doctor? And Mary's shaking her head back there, and she says, no, I need you to go see an ophthalmologist.
So this is why I asked Mary Kay to join me, because you notice none of that was on the slides. She is embellishing, because she's a great speaker, and telling it how we hear it on a daily basis. So what is this MS pain? Is it an MS pain? Yes. What's it from? Optic neuritis, absolutely. This is optic neuritis pain. And if I want to reproduce that pain when the patient comes in the office, sometimes the patient's sitting there and unwilling to move their eye, I do a simple maneuver. It's called orbital ballottement, like floating ballottement. I push on the eye just a little bit. It makes the eye move back and forth, in and out of the socket, sort of, back into the socket rather. And that does the same thing as them moving their eye. And if they go ouch in a big way, that's optic nerve pain. And Amy already told you a little bit about that kind of pain. So, optic neuritis is also called retrobulbar neuritis. Why? Because a lot of the time the inflammation is behind the globe. So if I look in your eye, I can see the optic nerve right where it exits your eyeball. But often it looks perfectly normal in optic neuritis because the inflammation is behind there along the track of the nerve. It is probably one of the most common acute pain syndromes that we see in multiple sclerosis. It results, as she described to you, by swelling of the nerve. And what happens is that stretches what's called the dural sheath, which is the myelin, basically, around the nerve is being stretched, okay? Nerve itself does not hurt. Nerve from the central nervous system, you can put a knife in the brain, you don't feel that. There is no pain. That's why some neurosurgery can be done with patients awake. So the nerve itself is not painful. It's the structures around it, which include blood vessels, and distortion or distension of blood vessels hurts. And so do the meninges, the coverings of the nerve, which come from the same coverings as are on your brain, made by the same myelin-making cells. Okay, so we've got myelin around the nerve, and we've got meninges, meningeal coverings that get distended. So it's like having a meningitis of your eyeball, okay?
Are there only meninges in the optic nerve?
No, well, of the cranial nerves in your skull, like the nerves that move the eyes from side to side, the nerves that move your face, the facial nerve, those nerves also have myelin around them and covering, but those coverings are made by cells that are not part of the central nervous system. Those are Schwann cells. The cells that make myelin for the central nervous system are the oligodendrocytes. And it turns out that only the optic nerve, in its course through the skull, is still covered by central nervous system myelin, which is why it's a target of attack in MS. So, sometimes it's just a low-grade ache. Sometimes there's no pain with optic neuritis, but when it hurts, it can be low-grade, or it can be these intense stabs of pain with movement or with pressure on the eye. The good news is it will resolve as the optic neuritis heals. Almost invariably, people get over the pain, oftentimes long before they get over the visual loss. So we don't worry so much about chronic pain with optic neuritis, okay? What do we treat it with? And that's really my talk is supposed to be, what do you do about it? And you know, it turns out you can use some simple analgesics, non-steroidal anti-inflammatory drugs, OTC, over the counter, so Advil, ibuprofen, Aleve, Tylenol may work, but often not. More potent anti-inflammatory medication are steroids. And so we use steroids for acute optic neuritis based on trials that were done a long time ago, called the optic neuritis treatment trial, in which it was demonstrated that if you treat optic neuritis with steroids, you hasten the time for repair and resolution of the optic nerve injury. This doesn't change outcome long term. It appears that 6 months later, whether or not you took steroids, your optic nerve gets better. But early on, if you take the steroids, your vision gets better a little faster, and your pain gets better a lot faster. So that's a way of ameliorating the pain. Now, very rarely, it's not on the screen, I will have to use narcotics for optic nerve pain during the acute phase. For all that's out there about opioids and opioid addiction, we don't see that commonly in acute pain syndromes in MS when we're using brief episodes of narcotic medication. So it's not out of the realm of usefulness or appropriateness to do that in this setting.
Do people ever get bilateral optic neuritis?
Occasionally they do. It's rare. What more often happens is you have it on one side, and then a year, 5 years later, you either have it again on that side or on the other side. Optic neuritis in its recurrence does not necessarily produce more pain than it did before, and sometimes it doesn't hurt at all. Every so often, I will see patients who are complaining of a low-grade eye pain, and they're worried that they're about to get optic neuritis, and yet they don't. At least they don't get a visual defect. But I think we always have to bear in mind that low-grade eye pain, particularly eye pain with movement, could be that, but heck, it could be something else. Can you think of anything else in the eye that would hurt, Mary Kay?
Well, there's a disease called uveitis, which is an inflammation of part of the eye. That causes pain, right?
It does. It's more the front of the eye, not the optic nerve, and it also is autoimmune, and it also occurs with slightly increased frequency in patients who have MS, although uveitis is also associated with other autoimmune diseases. Sarcoid, Behçet's disease that you might never have heard of, and so forth, even lupus. But MS patients do have a slightly increased risk for getting inflammation in that area of the eye, the front, where you can have irritation in the cornea, or behind the cornea and the lens, and those kinds of inflammatory conditions of the eye can also hurt. So can glaucoma. So acute glaucoma hurts. And so you never want to make the assumption that it's optic neuritis. You want to get yourself to the not Walmart eye doctor, the good eye doctor who knows your eyes, who's seen you before, and who follows you on a regular basis. Okay.
So now we have a 65-year-old gentleman who's got a long-standing history of progressive MS, secondary progressive MS, and he's been on a medication called Gilenya for 2 years. He presents to the emergency room with, again, eye pain. Not left eye this time, but right eye. And it's significant. He tells the physician in the ER that it was irritated for a couple of days, but now he's sitting there with his hand over his eye because it hurts so significantly that he really doesn't want it exposed to the environment at all. It's also red. The
conjunctival injection.
And he's tearing. It keeps tearing in that eye. Now he's sitting there like this. Best we can tell, he really does not have any visual changes. His visual acuity seems to be okay. Now, he's moaning. He's also a man, so he has that low pain threshold, remember?
We do have men here, Mary Kay. Be careful, be careful.
I'm referring to my husband, okay? Poor guy. So he gets IV morphine. So, the astute female, medical student notes that there's a small rash, a couple of dots, over his eyebrow on his forehead on that side. Kind of up high even. So, any ideas?
What could be wrong with this gentleman? It could be shingles. Excellent, you all pass.
I told you they're smart.
Okay. So, are shingles related to MS? No, mixed opinion. Let me tell you about that. So yes, this particular version of shingles is called herpes zoster ophthalmicus, and it means shingles of the upper portion of the face that's supplied by the first branch of the trigeminal nerve. I think Amy went over the trigeminal nerve a little bit in talking about trigeminal neuralgia, and this has nothing to do with that syndrome. But if you get shingles in one of the branches of the trigeminal nerve, you have pain and rash in that distribution. And it turns out, unfortunately, that when people get facial shingles, there's a predilection for getting it, a preference by the virus to go into the first division, which supplies the eye. So people get this incredible, horrible, intense pain in their eyeball, and they get rash in the whole distribution, which means the eye itself is being invaded by the virus. by the shingles virus, which is herpes zoster. That's the same virus that causes chickenpox, okay?
And the cornea is affected in this, and the cornea is very sensitive. If anybody's had their contacts in too long, they know what that corneal pain, that corneal abrasion feels like, or an injury to the eye where the corneal is cut. It's horrible, and it's that horrible pain where you cover it and you keep tearing. And in this case, it's the herpes zoster that is attacking that eye, that nerve branch, like Dr. Green said, and irritating that cornea, and that can actually scar and leave a scar in the cornea.
In which case there can be visual loss, which means you need a prompt diagnosis and prompt treatment. So what do we do? Oh, before we say that, yes, what's the MS connection? There is an MS connection. So it turns out that people with MS have a higher predilection for getting shingles. Unknown why, but the incidence is higher, even in patients on no specific medication for their MS. However, we very well know that patients on Gilenya do have an increased risk for herpes-type viral syndromes. And herpes virus can cause cold sores, it can cause upper respiratory infections. There are different types of herpes viruses, but herpes zoster, the chickenpox virus, is one of them, okay? And this guy is 65 years old. Remember, all of our MS studies for the new disease-modifying therapies are age-limited, right? We purify our studies. We only let in the younger people because we don't want people dying during studies of other diseases, see? So they always make them, 18 to 55. That's it. We don't let people in who have other immune diseases, or people, sometimes they don't let people in who have diabetes or a history of malignancies. But when the drug comes on the market, who do we give the drug to? Anybody we want, who we think fits the diagnosis and the need for the drug. So this is a gentleman who's 65 years old, who's on Gilenya. And as people age, they have a higher incidence of shingles. And it turns out post-shingles pain can be worse and more lingering in people who are older. So these are the people who get a chronic syndrome. So we've gone from an acute to a chronic pain syndrome that's known as post-herpetic neuralgia. And that is very difficult to treat and very difficult to tolerate. And more common actually in women. Go ahead. So what do we do about this? We treat the rash promptly with an antiviral agent. This is one of the viruses where we actually have very effective antiviral treatment, unlike the common cold. And I'm on my 4th one for the year, so thank you very much to my grandchildren. Anyway, so we treat it with valcyclovir. There are other category medicines like that, but this is the most common, known as a trade name Valtrex. We often add corticosteroids once we have somebody on antiviral therapy because it can reduce the inflammation associated with the infection and therefore reduce the scarring to the cornea, and it can reduce the pain, and often does. So corticosteroids, anti-inflammatory steroids, are one of those great anti-pain things. And we know that they help pain of all kind. Lots of times we give somebody steroids for their MS and they go, oh my God, my arthritis is so much better. Okay? Steroids are a great treatment, but as you all know, they have their downside. But this is a situation in which acute management can obliterate that pain.
So what's going to happen next is this patient is going to get through the treatment, get this acute problem solved, feel better, not necessarily have that residual pain, but they're going to call Lisa and they're going to say, should I stop my Gilenya? What do we do?
And the answer to that is actually no, okay? Interestingly, before you go on Gilenya, we check that you have immunity to the chickenpox virus, because in one of the studies on that drug and in a patient post-marketing, they developed chickenpox and died of disseminated chickenpox. So we make sure people are as protected as we can get them from chickenpox. So if somebody doesn't have immunity, they get vaccinated before they start Gilenya. But in fact, continuing on the Gilenya is not prohibited at all. We treat the infection and we continue to treat your MS. And again, outcome for shingles in MS patients is no different from the general population. That said, because this patient is a little older, the likelihood of having post-herpetic neuralgia is a little greater, okay? At the time of acute shingles, and we had a gentleman in the office recently with this, narcotics are certainly indicated. Opioid medicines may be required to make the pain tolerable and get through the day, because it is a pretty severe pain. Once healed, long-term chronic pain, that is not what you want to use opioids for, and frankly, it doesn't work, because the post-herpetic neuralgia is nerve pain. And so we use things that are going to inhibit nerve discharges in order to manage that long-term pain. So what is the post-herpetic neuralgia? And that can be a pain that could be mixed up with normal MS pains. But of course, if you get herpes zoster ophthalmicus and you get over the rash, and yet you start to get this lingering burning pain over your forehead and scalp that never seems to go away, that's obviously going to be related to the shingles itself. Sometimes there are sensory changes in the area where you still have itching or sensitivity to touch or numbness or burning. Any of those types of symptoms are typical of chronic neuralgic pain. And so what do we use? We use anti-seizure medicines, because anti-seizure medicines, anti-epileptic drugs, have a second life, almost all of them, in treating pain syndromes because they inhibit abnormal nerve discharges. That's how they treat seizures, but that's how we also treat these nerves that have been stripped of myelin or damaged in some way that are discharging inappropriately. Just like with the Lhermitte sign, any direct injury to a nerve can result in pain like that. So you can see listed there things like Lyrica, pregabalin, gabapentin, which is very commonly used for pain, lamotrigine, which is not as old as some of the others, but we do use for pain as well. And other categories of medication, particularly antidepressants, also have a second life as pain medicines because they too inhibit this transmission, this abnormal transmission, by certain different mechanisms from one to another, by depletion of certain neurotransmitters. So such things as the old tricyclics, those are amitriptyline, nortriptyline, protriptyline. We had a whole bevy of those that 30 years ago we used for a whole bunch of things, including migraine headache. We use them less now because of the side effects, but in this setting, they are often very helpful. Duloxetine Cymbalta does have an indication for post-herpetic neuralgia. So some of these drugs are actually FDA approved. Lyrica is, Cymbalta is.
And then if there's a localized patch, maybe not on your eye or your forehead, we can use a lidoderm patch for a very localized place of post-herpetic neuralgia pain. All right, case number 3. This is a 37-year-old right-handed woman who comes to our office, and we're like looking at her when she's signing in. Jennifer's saying, what's up? She's holding her left hand out, and she has purposely got her left thumb stuck up in the air, and we're all thinking, oh, something's going on. It's painful. It's painful even to bend. It's painful to move or to come in contact with the other portions of her hand. She thinks it's because she cleaned her garage over the weekend and just overdid it and maybe hit it with a hammer or something was going on with that. But also, when she really thinks about it, there's some numbness related to that. And when she carries her purse, because she's used to carrying her purse as a hook on her elbow, she's having a hard time. She's had to empty some things out of her purse because she's noticed that she's weaker on that side and she's not able to keep that up. It's kind of drifting down. Now, she's been on Copaxone for 5 years and she's relapse free. Prior, she had a transverse myelitis and really pretty much recovered from that.
Transverse myelitis is spinal cord. So her original attack years ago was a spinal cord attack, and it left her with a little bit of numbness in her hands, but nothing to write home about. Nothing that interfered with her function. But now this thumb is killing her. She can't let me touch her hand.
And not only that, once she gets into the exam room and we ask her some questions, try to elicit some information, she says, I'm a little achy up here. I think I kind of slept wrong in addition to probably overdoing it in the garage, and kind of just down my arm and my shoulder. It just doesn't feel right, in addition to this weakness when she's holding her purse.
So, if this lady did not have MS, what would the doctor be telling her?
Heart attack, stroke.
Oh, for God's sake, yeah. How old is she?
35.
Don't jump to heart attack and stroke. Pinched nerve. Isn't that what they always tell you have? Even when you have MS at the beginning, they say you got a pinched nerve. The problem is a pinched nerve is the entire spinal cord, but let's not argue details about that, right? So if she did not have MS, it's a slam dunk. This is what I see in the EMG lab when I do electrodiagnostic testing. Come in, pain here, goes down my arm, tingling in my thumb. But the problem with this, it was the intensity, the severity, and nothing can touch it. You don't usually see that. What's the pathology in the neck? When somebody has a pinched nerve, what are we talking about? What's pinching it? What? Something's pressing on it. What in the neck, not in MS, can go wrong and press on a nerve? Bones can, yeah, so you can have a bone spur. So my husband's friend decided he was going to work out when he was 40. He had that midlife crisis, and he decided to do trampoline jumping with weights in his arms. And he came in and he had damaged his C5 nerve root, couldn't even lift his arm, had no biceps function. C5 was out, but it was a stretch injury and he got better, okay? So what else pinches a nerve besides a bone? What do we have between the vertebrae? Discs. What do? They rupture. And that happens often in young people. So I'm sitting with a young person with MS whose disease has been perfectly controlled for 5 years, who hasn't had any problems, who's got pain down her arm and into her hand. And young people, by the way, slip discs all the time. They do. It's a common disease. So I would like this to be a slip disc, frankly, because that's easy to fix. The surgeon can fix it, or we give her some anti-inflammatory medication, it gets better. But it's not a slip disc. Okay, so what has she got here? This is the spinal cord, okay? The gray is the spinal cord. But what's wrong here is this. That is an area of increased signal on FLAIR imaging that's elliptical and angry looking, and that is an acute plaque. That's an acute MS plaque. And if we take a cross section, circle that thing. The spinal cord is the little gray circle. The plaque is that big white blotch. And it happens to be right at the level of the nerve exit for C6. And anybody who knows dermatomes will know that each piece of your arm is supplied by one particular nerve root in the neck. That's how we're neuroanatomically organized. So when you talk about sensation in the arm, if you have a numb thumb, that's C6. If these fingers get numb, that's C7. If these get numb, it's C8. Okay? That's just how it's organized. So she's got C6 numbness. I was hoping for a C6 disc, but lo and behold, she's got a plaque. She's got a big plaque. So why is she weak? Because when you flex your arm this way with your biceps, that's mainly C5. But when you flex your arm this way, that's C6, and that's how she holds her purse, right? So she's got a little bit of C6 weakness.
So 5 this way, 6 this way.
It's a different muscle. Biceps is this way. Brachioradialis is this way. It's a different muscle. And brachioradialis relies on C6, biceps on C5. So she can still bend her arm, okay? But she's got this exquisitely horrible radiculitis, pain down a nerve root, but from her MS. So radiculitis occurs in MS. It can be acute or it can be chronic. And it relates to demyelination right at where the nerve root goes out. Okay? So it mimics the pain of a disc rupture, and you have to rule out a disc, And sometimes you can have both. So sometimes you can have long-standing MS pain down a limb that gets much worse because you rupture the disc. That's a fixable thing. Surgeon can go in there and nab the disc, and that can relieve the pain. So that's a setting in which surgery might help a pain that's MS-based but has been magnified by structural disease. Acutely, when you do have a ruptured disc, like I said, we might give you steroids, but in this case, we're treating a relapse. And if we treat this relapse quickly with Medrol or high-dose oral prednisone, we might lessen the pain fairly rapidly. But over the long term, this type of pain, radiculitis, is going to again require medicines that inhibit abnormal nerve discharges. And I list for you again some of them. Dilantin's been used for this. Dilantin's a way old drug for seizures, but it also, like Tegretol, carbamazepine, or lamotrigine, or Lyrica, has an inhibitory effect on nerve discharges. So if you're allergic to one, we move on to another. If one doesn't work, we use a different. Sometimes we have to use two of these drugs together. And unfortunately, all of these medicines, although many are effective, can have additive side effects, can make people tired, can make people dizzy, can make people more off balance.
So Kim gets a call from this patient who has not long resolved and is left with a little bit of pain, a little bit of numbness in her thumb, and 2 years later, it's a day like today when it's 97 degrees and 90% humidity, and she's been out gardening. She went out early because she knew to avoid the heat, but she came in and this pain is so much worse. Is that something we need to evaluate? Or Kim, what are you going to tell her to do? You guys can join in too. Cool down, right? Ice up, cool down, and it should go away. Because that's a magnification of an old symptom that has been intensified by, in this case, heat.
And the same could be said if you get infected. You know, all the things that cause pseudo-relapse can also intensify MS-related pain symptoms if that's your major chronic problem. So we talked about the disc can mimic this. Degenerative arthritis of the spine with nerve impingement can mimic this. Also, every now and then, somebody comes in and says their thumb is numb, and it has nothing to do with MS. So we always have to think of comorbidities, like carpal tunnel syndrome, okay? Carpal tunnel usually does not cause pain as intense as what this woman described. And that was just because my daughter likes clip art. It's a little scary, huh? Okay.
All right, now we have a 44-year-old gentleman. He's got a 5-year history of mild relapsing MS, and he complains of painful spasm. I think Dr. Roshway did a great job talking to us about spasm. But for 1 month, these spasms have increased. And he tells us that he has a sudden pulling in, and this would happen, it'd last for a few seconds, and then it'd go away. But it continued to happen about 10 or 15 times a day. It was horrible in terms of pain, and it certainly interfered with his life. He was afraid to drive because he didn't know when this might happen, and he might hit the gas pedal or lose control of his car.
And you can imagine a pain that only lasts 10 or 15 seconds, there's no point in going and popping anything, right? You pop an Advil, it's already over. You take other over-the-counter pain medicine, even narcotic, it doesn't really work.
And you go to the ER, and it's like taking your car in when it's got a beep, it doesn't, or a crack, it doesn't do it when you're there, right? Same thing would happen here.
So, when episodic things happen, particularly at the beginning of MS, they can be confused with another neurologic disease. What is that? So if somebody comes in and they say, I'm having spells, episodes of.
Are neuro nurses, any ideas?
Seizures. Thank you, Mary. Excuse me. So, small seizures, called partial seizures or focal seizures, can just produce a very transient behavior, right? So, in little kids who have petit mal, they might just blink for a few seconds and then the seizure's over, right? In people with focal motor seizures, they might have a posturing or they might have a little twitch. So very often, if that's the first symptom of your MS, and I have a number of patients who started out with this syndrome of tonic spasms, they were thought to have epilepsy. And so the first test that's obtained is a brainwave, okay? Now bear in mind that a brainwave test, if done during the seizure, is usually positive. You'll see the seizure activity on the brainwave. But done between episodes, you might miss anything. So having a normal EEG doesn't rule out seizure, okay? But the next test helps a lot, because then the doctor says, well, if this patient is having focal seizures, maybe they've got a tumor, or maybe they've got a calcification in the brain or an old scar that's causing seizures. So the next likely diagnostic test for this is an MRI brain scan. And of course, that then is very helpful in revealing that a patient may have multiple sclerosis. So if this were the first symptom of MS, the MRI is diagnostic for us, okay? If somebody already has MS, it's very easy for me to diagnose tonic spasms when they call me up on the telephone and describe this, okay? This person also has an MRI of the spinal cord, because sometimes the neurologist thinks, is this some weird pinched nerve thing? And so it's helpful to also get the MRI of the cervical cord. That just confirms further that this gentleman has MS, and we've already named it. It's called tonic spasms of MS. The other name for it is paroxysmal discharges of MS, because it's as a result of sort of a reverberating circuit of abnormal discharge coming out of the same place each time.
Well, this guy still wants to go to work. He wants to be able to use his mouse. He wants to be able to drive. How are we going to help him?
And we are. So, just to clarify, it doesn't have to be a motor spell. So I had a gentleman who said 15 times a day, hot oil was being poured on the top of his head, going down one whole side and out his foot. Intensely painful. Did he move during it? No. Did he twitch? No. So there are motor types of tonic spasms, and there are sensory tonic spasms. They're painful very often. Both are readily treatable with the same category of medications that I've been talking about. I would tell you that carbamazepine is probably the best to start with. Oftentimes gabapentin is used first just because regular doctors, internists, are used to using gabapentin for pain, and they may not recognize this as a tonic spasm, but it turns out that anti-seizure medicines are very effective for a phenomenon that's not a seizure that occurs in MS.
So just a little side note about carbamazepine. It's also a brand name called Tegretol. It's often we use it in pediatric doses, and the medication instructions from the pharmacist will say, chew this medicine, because they think you're a kid and you're taking it and they don't want you to choke on it. It is god awful. So if you ever get prescribed this medicine, don't chew it, swallow it.
Okay, but I have to tell you, a couple of my patients like it. And they say, oh, I love that cherry flavor. And I go, okay, you can have it. By the way, oxcarbazepine is sort of a derivative of Tegretol that's also known as a trade name Trileptal. So it has a similar mechanism of action. Sometimes people tolerate one better than the other. Is there a test that reveals whether you've been exposed to chickenpox? Yes, it's a blood test, and it shows whether you have immunity to chickenpox. So it's easy to find out. We do it all the time. That was the easiest question. Are MS patients supposed to get the shingles vaccine? So there's debate on this, and it turns out that the shingles vaccine is a live type vaccine, not a killed virus, and we worry about live vaccines stimulating new attacks in MS, okay? So originally it was advised not to. We are now, there's now felt to be enough safety that older patients who have a high risk for shingles, we encourage them to go ahead and get their vaccines.
Now, if a patient has had shingles already, do we get the vaccine?
The immunity you get from shingles, I think, wears off, and you are still a candidate for getting the vaccine. Okay, taking steroids not recommended by eye doctor. Long use. Oh, okay. So yeah, so chronic use of steroids Corticosteroids used over months to years can have a variety of adverse effects. Weight gain, hyperglycemia and diabetes can occur. Thinning of the bones, so people who are on long-term steroids for other autoimmune diseases, we never do that in MS, but for other autoimmune diseases, unfortunately can get collapse of the spine or spinal thinning. Can get, sometimes with acute steroids, just a pulse of steroids, you can get what's called a vascular necrosis, which is sudden deterioration in the hip joints or the shoulder joints. So we don't take these lightly. The chronic use to the eyes, steroids can cause cataracts. So if you've already had your cataracts out, they're not going to injure your implanted lenses, but long-term steroids can accelerate the development of cataracts.
Can you have arm or neck pain in old age? Of course. Most likely, if it's not an MS source, it's going to be an arthritic or bone source, but that needs to be evaluated if you have the diagnosis of MS to make sure that it is structural in nature versus MS in nature. And that may include numbness.
These questions are not really about pain, but somebody has a friend who has abnormal eye movements and they seem to be increasing. Does he need a special MS ophthalmologist? Well, he needs a good ophthalmologist, and he may need referral to what's called a neuro-ophthalmologist. And so neuro-ophthalmologists specialize in neurologic causes for eye disease. And that can include optic neuritis. Sometimes we send our optic neuritis patients to the neuro-ophthalmologist. Sometimes the neuro-ophthalmologist takes care of our patients with MS who have nystagmus or double vision or other kinds of eye movement abnormalities. So yes, that's helpful.
I have another vision test that goes along with that. When you see an ophthalmologist, they also may test for your visual field. How well you see around the edges, how well you see in the middle, and that again is important to help us sort out, are things MS related, or do you have a detached retina? Or are there other things going on? So that's important. So when we have you see the ophthalmologist, not only are they looking at MS, they're ruling out other kinds of eye diseases.
Anything you want me? Can looking at the computer screen, iPad cause or aggravate optic neuritis? No. As in all of MS, you can fatigue the nervous system. So if you have numb feet and you go for a hike, your feet get number, that just means you're fatiguing the neurons that are doing most of the work because you have some neurons that are not able to do the work. At the end of the walk, you cool down, you rest, and you go back to your baseline. You cannot damage the nervous system additionally by simply using it. So by the same token, if you have optic neuritis and you're straining to see and trying to do work on your computer, you're not going to injure anything, but you are going to fatigue, and by the end of a session, you may notice that your eye is a little more blurred.
And so kind of along those lines, how do we rule out pseudo-relapse versus real relapse? And again, it's all about, are we causing new damage? If there's old damage that's been exacerbated and or magnified, it's the word I like to use because the other sounds like a new attack. Magnified because of heat, infection, stress, visual stress, cognitive stress, motor stress. Once you return yourself back to a plateau, an even basis, your symptoms should return. If it is a true relapse, it's a reoccurring symptom that can't be explained by something else, no bladder infection, no 95-degree days, that lasts continuously for about 24 to 48 hours. And that, if you're having trouble, that should be sorted out with your healthcare professional. So give them a call.
Thanks for your attention, everybody. And you get part 3 now, which is not medicines. Lots of other ways, and many of you know our next speaker, Nancy Dolenmeyer, who's our premier MS therapist, and you're very lucky to have her here as well. We're all very lucky. Thank you.